third webinar out of the 7 webinars that we have planned this week, and the format will be the same, that I'll do a very brief introduction and then hand over straight away to Michael Cohn, who's the CEO of Tilla, and Christy Campo, who's the clinical director at Tilla, and they're going to talk to us all about the URICAP and the female urine collection device. I'm trying to find the right word for it, but anyway, that's it.
That's a good
what
word.
I would ask everybody is please mute yourselves unless you are going to speak. And secondly, can you please speak fairly slowly, because the audience, even if not everyone is here right now, is an international audience, and for them often English is not their native language, so it does help. Yeah. And for the rest, I think it's over to you, and I'm very curious to see what you've got to say. So I think, Michael, it's over to you first, and then
Thank
you
you.
can switch over to Christy. Yeah.
Yes,
Thank
we
you.
will. Thank you, Lynn. Thank you, Margaret, for inviting us to this webinar. It's our pleasure to be able to present what we think is a unique new way of collecting urine that might change the way we approach this global problem. And as you understand, I have with me Christy Campo, my colleague, who is director in the US for clinical and client services. So today's the agenda here for the next slide is I will make a short, brief introduction on of URICAP and also the Tilla company, because we are fairly new in the market. And then we will look on URICAP female as a device that can really change the continuity of care. And we're talking about urine incontinence, which is a global problem, and the global impact that could have. And we will then cover how it can affect the personal side, the medical, diagnostic, the healthcare industry, and the society at large. Small little device, we hope it can make a big change. And then we are very happy to answer any questions you might have. And Christy will assist me here. So these are the pictures, and we have a LinkedIn, so you're welcome to connect to the company and follow us through LinkedIn, where we're quite active today. Thank you. Christy will introduce herself also. She has a PhD and has a commercial experience of getting a new product, innovative product to market. She can tell you a little more about that. Christy, maybe you want actually to introduce yourself shortly.
I would. My name is Dr. Christy Campo. I'm a doctorally prepared registered nurse. I have an expertise in general medical surgical nursing, patient safety, and my role here at Tilla is to lead the scientific and clinical implementation of the URICAP in the leading United States hospitals. So I look forward to working with everyone here today. I'm very proud to be a part of this presentation. Thank you.
Thank you, Christy. So my background is I'm the co-founder of the company, and part of being the innovator, and has worked as a CEO now for 2018, making this a product ready for the market. And that's the short version. We're looking at the benefits. What are we addressing as with the URICAP female? On the personal side, we know chronic incontinence is very detrimental to sleep, social isolation, and hygiene, and causes a lot of problem on the personal side. We have in the market 2 solutions. It's a catheter and it's the adult briefs. And there has not been much development in the past years. We're going to also cover vacuum-based, suction-based devices. On the medical side, we know that incontinence and women have a very high rate of UTI, recurrent UTI, and with the catheter you have the CAUDI, which is a big problem in the hospitals. And we also have the wound problem. We'll cover that. And on the healthcare side, we have cost. It's a very, very a big problem with a big restructuring of the healthcare industry, especially in the US and globally after COVID. And cost is in the forefront of everybody's mind. And we're talking about total cost, not a cost for a device. The cost of incontinence globally is huge. And we will look into that arena too. And we have the societal cost because that's paid in some countries by taxes or insurance company. And we also have a sustainability issue. We need to get down and decrease the use of antibiotics, and environmental sustainability issues are also something that is affected by the huge number of incontinence. So we can go to the next slide. And this is about everybody. Everybody knows this problem. Everybody had a mother, or you gave birth. Incontinence is something that almost 62% of adult US women aged 20 and older suffer from this condition, according to recent studies. And this is just growing. It's growing with obesity. And when EuroCap, we address women with moderate or severe incontinence, and it's a huge number, 27%. I made calculations on 12%, but this recent study more than double that number with the addressable market. And if we go from the personal to the societal, I don't know if you know that 5% of all waste comes from adult diapers, adult pads, and half of that is incinerated. So we are basically with the problem with oil prices and gas prices, we are incinerating to 50% of that waste. That means that we are burning about half a liter of water for every full diaper that we're incinerating. And the amount of oil or energy to do that is mind-boggling, actually. So this is something we that needs to be addressed. Next, Christy. So if we look at the disease, at the burden on the healthcare and the disease, the urine is a toxic substance. It has the wrong pH, and it actually hurts and damages the skin barrier on anybody laying in with humidity or moisture from urine. And you have incontinence associated dermatitis, you have moisture associated dermatitis, and ultimately you have wounds too, which are extremely costly and time consuming to heal. If you're in a hospital acquired infections, most common is the UTI or the CAUTI. And most hospitals today have strict regimens to decrease the amount of catheter days, because if you can do that, you can decrease the amount of infections, catheter infections. And ultimately, you can get sepsis. In the US, about 13,000 people die from sepsis as a result of UTI. And the correlation with incontinence and falls and dehydration, social isolation, embarrassment is well documented also. So we're talking about huge areas of cost of care, readmission of patients that cannot manage at home, and you have a breakdown now on the long-term care side after COVID. So this is hyper interesting areas that needs to be dealt with. And you have a total burden about a market which costs about $65 billion per year. And I think I wonder if that's the US number only. But it's a huge burden. Let's continue. So what we did here is that we were told that there was a huge need for a female urine collection device, we actually developed a male one first. So we have actually a patent for a male one, and as I'm a doctor and I know the problem in the hospital since many years back, we started developing a female, and it's for the patient, and the idea was not to use any mechanics or any holding devices or any pumps or electronics. It should be something that every patient can use themselves without any additives. Thank you. Next.
Next one's the video.
Oh, the next one is the video. Okay, so we made a little video that can explains what it looks like, how to use it, what you have to think about, and additional use is actually taking a clean urine sample, and you will get this video here. So let's start the video so you can get an idea of what this development project
Tilla
turned
is
out.
proud to introduce the Uricap Female, an external urine collection device. Uricap Female is a simple, comfortable, and quick-to-use device that enables effective urine management. The Uricap Female is assembled from the cap and the tube. Connect the cap to the tube. Connect the tube to a urine bag. Make sure they are firmly connected. Apply the lubricant around the edges of the device. Clean the vaginal area before applying the device. Hold the Uricap Female with your dominant hand. Place the index finger in the longer lower lip of the device. With your non-dominant hand, spread widely the inner and outer labia. Locate the top of the vaginal opening. The device is placed in the area above it. Attach the long or lower lip of the device to the vaginal opening. Using the free thumb, tip the cap upward to make full contact with the area around the urethra. Lightly push in and hold in place for 5 to 10 seconds. Close the inner and outer labia around the cap. Only then remove your dominant hand. Fasten the tubing to the securement device where the extension piece meets the drainage bag. Allow enough slack in the tube and secure to the inner thigh. To remove or change the cap, simply spread widely the labia and gently peel the cap from top to bottom. With the Uricap Female, the patient may enjoy a full quality night's sleep, all while staying dry, clean, and comfortable.
Thank you. So this is a film. You can find it on our webpage and look at it. And basically, it's very quick. You assemble it, and it's quick to apply. Basically, it's important to inspect the area, clean it, and apply the device according to this movie. It's from our studies, we've seen it's a fairly fast learning curve for the staff. But you need to, the most important thing is to validate and make an assessment of the patient, and to then it's fairly within 1 to 5 times. Some nurses are very ambidextrous and can put it in right away and understands quite away. So it's basically very similar to putting a catheter in. It's not big, but it's not. It is not. Sterile procedure. The device can, if when it sticks there, you can sit up in a wheelchair. You should, we recommend it to be partly immobile patients, users, nighttime use, or bedridden patients, or patients that are sitting up. And if there's movement, you have to check and make sure the device is in place. It can be used for 24 hours, changed daily, and you can use it every day. We have had patients using it regularly for over a year, or even in our study for over 30 days in a row. Next, please. So this is a very innovative device, as you can see, placed right when it sits in position. It does not leak. We have all the urine in the bag. It's external, so you avoid any infection risk. That's why you don't need a sterile procedure. It's soft, the silicone extremely soft and comfortable. We eliminated all hard parts in there, so it's very evenly soft. And you also, as a bonus, get the urine visible in a standard urine bag. and can validate the amount of urine per hour or per day. And another added value, you can use it to take a culture. Today, in many incontinent women, you do a straight cath, and if they don't have a UTI, you can also cause it by the straight cath. We can eliminate that risk. So that's some of the basics of the UriCap female. And you use it daily. So the question is, so how come this works? What is the mechanisms here? And what we found is that the surfaces, when very close to each other, the smooth surface around the urethra and the smooth surface of our device creates a kind of a surface adhesion. You know, two pieces of glass with water, when they get close to each other, you cannot separate them. They're very, very tight. And if you put and just separate them a little with a screwdriver or whatever, they fall apart. So the closeness of the surface is very important. And there's also the labia folds, holds it in place and prevents rotation and holds it in place, because over time the adhesion increases gradually with each event. Event of urinating, you get the device to get closer and closer over time. So we recommend to be still for about an hour after application. And these are the mechanisms. There are some other secrets there, but we're not talking about them here. So we have been working at this for a long time, 2015. It's not something simple. We have a very good silicone that's high grade. We don't have any toxic reactions and well tested. We don't have any other adapters or anything. We have the patent, the first national patent approved in China. We are patent pending in other places. We are FDA, CE, MDR approved class 1 device. And this, what we're now bringing to market, is the third generation after trials and pilots for over 2 years. So we have an optimized design, and we're in full production. And our challenge now is, of course, the implementation of a new device in the healthcare industry. And we realized that this is a challenge. And Christy has long experience, and our team, we have a graphic team and design team, and we produced a number of tools that would help, and Christy will go further into how to train staff on putting it in. And this device can be put in not only by a nurse, but a CNA or a caretaker or a relative, the husband or someone. It does not require, after proper instruction, a medical staff. So the implementation part, Christy will go further into that later on. So we can go to the next. So the company has been in working on this since 2013, or we started 2013. And the 2018, I got into the company, and we have then discovered this mechanism. And we had COVID in between, but we managed to do a few studies even during COVID, and putting it into the US market. And from, as you know, going a little under the radar, it's very important to get feedback from the healthcare sector, from the users, from the patients, from staff, how to improve the product. And we think we have now the product that's ready to really change the way we think about incontinence, and how and the market and the patients really need another tool, because there is a lack of useful tools. So we are very excited about bringing this into market, and we get a huge response from hospitals, from individuals. And our challenge here is now to meet up these expectations. But we are in full production, and we can produce tens of thousands of these devices every month. So we hope we can get there very quickly. And since 2021, in November, we have a long list of hospitals being very interested in piloting and working with us. Thank you. And I think it's time for Christy to take over here.
Sure, absolutely. Yeah. Well, thank you so much. So, when we think about the EuroCap female, we certainly want to be viewed as a global company. We are a multinational company, but our approach to care considers the patient and the full scope of their life and the full scope of care, home, acute care, long-term and post-acute. And Michael will certainly reviewed some of the personal aspects of the device and how it affects the individual woman and even the family, but also for us as individuals, as a company. So appreciate that bit of sharing. I'm going to spend a few minutes on the medical and the healthcare aspects of EuroCap and how each of you could possibly view it when you consider your current setting, your role, and your impact within the healthcare system where you work. So one of the things that's a great benefit to using the EuroCap is, again, through the continuity of care, no matter where our female patient is, we have an opportunity to support her, whether that's long-term care, whether that's hospitals. But from the healthcare system perspective, we all experience concerns and pressure to perform in a more effective manner. There are national programs that monitor urinary catheter infections, CAUTI, that monitor wounds. A variety of programs are out there that ask us to decrease prescription use using antibiotics, and certainly to prevent the many effects of incontinence that Michael mentioned earlier in the presentation. He also mentioned a really important and up and coming topic of the lack of sustainability with adult pads and diapers. There's a negative global impact there. And with each of the negative consequences of infection, of incontinence rather, we have to think about the dignity of the female patient that we care for. So we certainly have a goal at Tilla Care to improve the lives of the women that we work with. And again, whether that's in the hospital, the long-term care setting, or in the home care setting, we want to be able to offer this solution and also address issues of infection and skin damage in all of these settings. So our current clinical available options are pretty long-standing, if you will. The indwelling catheter has been around. If you read, there's a couple of really good articles on the history of the indwelling catheter since for about 2,000 years. And that's a really interesting one, not for today, but absorbent products have been around for also a very long time, and suction-based urination devices are relatively new to the market. But I think what's important is to consider how they fit the market and how they impact the patient. This audience in particular is very well versed in the negative consequences as well as the risks associated with indwelling catheters. Most importantly is CAUTI. Those catheter-associated infections have major costs and major life impact on our patients. And again, Michael went through those details. But also with the indwelling catheter, obviously, the person who's applying that catheter in the acute care setting and long-term care setting have to have a very particular skill to apply the device or insert the device using sterile technique. And then with that burden on the facility to maintain the skill of that nurse or whoever's inserting it, and then to also prevent those infections, which are commonly related back to the technique. So there's certainly safety issues there. And the device itself, indwelling catheters had very, very few improvements, with the exception of the addition of sterile technique in the 60s and 70s when that became widespread. There's been very few major revolutions in the indwelling catheter. Michael mentioned the environmental aspects of absorbent products, so I won't spend time there, but I think we have to recognize that absorbent products, although they're useful, they certainly take space on your shelf. They take time from your staff to change every 1, 2, or 3 hours, and a burden on the family if they're turning the patient and changing the diaper or pad on that patient. And outcomes are mixed. Certainly they serve a purpose, but we know that the skin is damaged in contact with those absorbent products, and there's a lot of literature support that. So many different risks there that we hope that the EuroCap can address, both for indwelling and absorbent products. You may or may not have experience with suction-based catheters that are also external, but these too take away valuable resources for the healthcare setting, whether it's acute, long-term, or at home. Suction-based canisters, again, suction should be used for nasopharyngeal suctioning, for the suction related to wounds, for chest, negative chest pressure. So many high acuity concerns can be used for the suction. When you take that away for external urinary suction, you really take away a valuable tool from the nurse. Also, if you've not been in the acute care or long-term care setting to see an external catheter in use that uses suction, what happens is fecal contaminants are actually sucked across the device, across the female's perineum and into the suction canister, which can also be a visual concern for the patient. But for all of us as practitioners, we have to recognize the urinary meatus is then contaminated. So that creates another risk. And then mobility. When a patient's using this type of device, they're really set in bed or in chair, unable to move away from the wall suction, because those suction-based external catheters do not work unless the patient is there tied to that external source of suction. And then just to build quickly on something that Michael had mentioned, you know, diapers and pads are certainly universal, they're common, but what we may not be recognizing truly in our patients are the concerns that relate to dehydration. Many women, you see data here to support 20 to 30%, may be dehydrated because they tend to hold back and not drink. That's a severe problem because that affects their thirst drive and our ability to measure urinary output. So dehydrated women, men altogether, confusion increases, fall increases, that may increase their length of stay because they've had an injury related to that fall. And then certainly there's the potential for a frequent readmission. And on all of these, our healthcare facilities have a negative effect financially. So one of the things that we really are excited about is certainly the evidence we have to support the adoption of the URACAP. So I'll spend just a moment here, I'm trying to watch the time, on some of the current evidence we have to support the URACAP. And certainly, Michael, hop in at any point as you desire. Okay. So our 2017 clinical study began with 3 independent nursing homes in Israel, where we recruited 30 females. And in those few females, only 30 females, 756 URACAP device applications were performed. And the outcomes here demonstrated that the device, the URACAP, performed in a leak-free manner, and that urine was collected as intended. And that's certainly the goal. We want to collect urine, we want to prevent it from coming in contact with the skin, and also reduce the use of pads and diapers that also have a negative impact on the skin. Most importantly, as a patient safety expert, I love to see that safety was clearly addressed and that there were 0 adverse events in this particular study. When we move to the next study, our clinical study, here we did 2 Israeli hospitals in an independent clinical study. Here, 14 female patients were recruited. And correct me if I'm wrong, Michael, this was conducted during COVID, correct?
Yes.
So also, you know, considering the additional hurdles of conducting research during COVID, during this study, 149 device applications were performed. And on the tail end there, we had individual women who were able to wear the device for up to 34 days before the device trial ended. So that's really, really encouraging data to support the long-term use of the device. And from an outcomes perspective, we studied performance, safety, and patient and nurse satisfaction. Our findings here, multiple variables were explored, including the urine volume collected, whether there was leakage or not, the quality of the device connections, safety. We explored a variety of adverse events, including side effects, and then satisfaction of the nurse, the user, patient comfort, and the ease of application. And the broad response here, again, was that device performed as expected. There was leakage, and we've ultimately revised the device up to this 3rd generation where we're at. And then it has a very safe profile, with nurses and patients being satisfied with its device use, the comfort, and the ease of application. And the last study I'll report on here was most recently the Tilla clinical study. And I'll just preface this briefly. Michael mentioned, again, one of the benefits of the URACAP is that we can collect a clean catch specimen from an incontinent female. And to the best of our knowledge, there's no other external collection device that can perform that particular offering. So here, our goal was to evaluate the sterile single use of the Tilla device for the purpose of urine sampling in women who were able to void completely. So these are fully continent or mild incontinent women. In this study, we recruited 29 females, and again, the 29 applications were performed for the purpose of the collection. The ultimate result demonstrated that only one of the 29 samples were contaminated. So you can see the data there on the screen. Ultimately, no adverse events, high satisfaction scores for both the convenience of use as well as the ease of insertion or application. Again, it's external. And what we see when we compare these results to the current literature is that the contamination rates of our device for the purpose of urine sampling for a clean catch were well below the contamination data reported in other studies investigating the same target population. So again, a really unique aspect with solid data to support its use for this specific purpose. Michael had mentioned also that we've had ongoing trials across the United States in both nursing homes and home care, where we've had collaborative efforts with our distribution partners that include AMT, Restorix, who've recently merged, and Gordian. In this example here, I share with you that 15 nursing homes, each having 1 to 2 patients per nursing home, have been using the device continuously now for over 12 months. And we've been, again, able to complete training, advise our partners via the phone and Zoom throughout COVID. So we certainly have the means to support URACAP use on a broad national approach, as well as on an individual approach for the those individuals in each facility who need specialized care. I'm going to spend just a moment on implementation, and then I'll hand it over to Michael because I think we're doing okay on time. So as we implement the URACAP, what's really critical is that we select appropriate patients and we give exceptional perineal care. And I can tell you retrospectively and anecdotally, as we go into the clinical setting and work with our hospitals, what we're finding now that they're using URACAP, they're actually performing better perineal care, which would ultimately, and I say anecdotally, improve the risk of infection if we're doing great peri care throughout the use of the device. So the indications for the URACAP are those women who are incontinent, and that can be either partial or complete. And these women tend to be immobile or partially immobile. We certainly want them to be able to move from the bed to the chair after they've had that device in place for about an hour, and from the chair or the wheelchair back to the bed. So these women tend to be at risk for dermatitis, different pressure ulcers, and these again are the great patients where we want to address their skin risks. We're also well fit for patients who are post-surgery, who are anticipating prolonged immobilization, or have particularly been assigned strict bed rest. So any woman who is incontinent and in need of a clean catch urine sample for analysis, as well as accurate fluid monitoring. And then building on that, think logically to the video. When you see the device's application site, you really have to do a phenomenal assessment. This is part of our daily care for every woman that we take care of. So before selecting the patient, be sure that you've ruled out those who are not appropriate. And those would be anyone with a periurethral or perineal rash, itch, irritations, wounds, or other symptoms in that immediate area. And then also, we should never apply the URACAP to someone who has a pelvic prolapse, an allergy to silicone, which is an incredibly rare statistically, urine retention, existing infections. And then for any woman who is combative or unable to follow directions, we certainly need to be attentive to the priorities. Is it more important to protect the hands of the woman so that she can then have the device to allow a wound to heal? Or is it more important to have her hand freedom and to not use the device? So again, clinical decision making there is really important with a combative or uncooperative patient. I love that we really, and it's one of, I think, our strengths, is that we always think about the patient and strive for patient-centered care. Here, whether you're on the short-term care or whether you're in the long-term care setting, we want to keep the patient in the center, but we also want to think about full continuity of care. In the short-term care setting, acute care, we're looking at the focus of preventing CAUTI. We've had excellent results with our nurses and facilities in the intensive care setting, where the device is very effective. Those patients in particular who have cardiac issues, especially when they're receiving diuretic treatment. Our nurses in the ER are finding that the device is easy to use for clean catch, as well as for a quick urine sample and to assess output in the ER setting. Again, other examples are orthopedic, as well as palliative care at end of life. So again, shorter term use. When we think about the patient in the long-term care use, we can certainly think about advanced care, post-acute hospital, and long-term care. Our patients here in particular are well suited to use the device when it's applied late in the evening, when there's going to be a naturally occurring rest period, so the device can stay on for the first hour and adhere well through the night, and then sleep with the device for the entirety of the night. The device can be removed in the day when they're much more mobile, but again, that allows them to truly sleep throughout the night, again at home or long-term care setting. These are particular good settings for the prevention of dermatitis and then those reoccurrent UTIs. Who's truly driving change? Nursing care has changed. I can only speak to the United States truly, but nurses are the ones who are driving change, and whether they're leaders or educators, patients are asking for the device, but nurses are also in the acute care and long-term care setting asking for new approaches and to adopt innovative approaches to care. So we work directly with the nurses in the units, the CNAs, the nursing techs, to help address the needs of the patients. And then we're routinely contacted by, from the home setting, caretakers, life partners, spouses and relatives who want something new for their family member. In these settings, we're often asked to perform with a short pilot where we'll do some training and then implement the device on a broader scale. And in each of these settings, we look for and build up a local champion so that we complete a train the trainer type scenario. Buy-in from both management, nurses, and family members is always important, and that's a critical part of adoption of innovation and change. And then we certainly look to drive that change across not only a single unit, across a department, across an organization, and all of their system. We've developed, as Michael said, many device training resources and educational materials, and I'll give you a quick hint at those briefly. If your organization is looking for a single department trial, what we do is train those specific clinical champions. We use an LMS-enabled, a learning management system-enabled cloud-based training, and we perform custom live skills training sessions virtually. Then if you're going straight to adoption and not doing pilots, you certainly, some are going to be widespread adoptions. We'll go straight to broad-based implementation, where we'll train a variety of users throughout the organization, again, using that web-based, cloud-based learning management system and a variety of resources. Then we come on site in stage 3 to help those clinical champions that we've built over time and support their more complex applications and patient selections. In terms of the learning management system, we have a cloud-based training system, and what you're seeing here in front of you is certainly just a few images, but our nurses and clinical champions are provided access to this training course that is systematic, goes from simple to complex, some content, some interactive learning, and some quizzes throughout. You get to read and listen to the training, so however you learn, the way you learn can be addressed in this system. And it is intended currently for those clinical champions and expert nurses. And then again, a variety of resources for facilities, whether that's a user skill tool as a checklist for skill evaluation, whether it's a quick reference guide, a single page document as a quick reminder if maybe it's been time since your training and you're now applying, device evaluation forms as you collect data. You've already seen our video, and then our demonstration kit. Our demonstration kit is a skill trainer with a URACAP and an extension tube so that we can appropriately train in the actual skill of applying the URACAP. So I spent a few minutes, Michael certainly spent time on the personal aspects. I've hit on some of the medical and healthcare complexities, whether it's the nurses, the system, the units, the complications, as well as some reimbursement. Michael's going to spend time next on the aspects that hit society as we move through and focus on costs and the environment.
Thank you, Christy. Thank you. Excellent. Yes, we would. The first thing in the U.S., the healthcare and globally the healthcare system, it's about what is effective for the patient, but also what makes sense from an economic point of view. And there was an independent cost value analysis made on the removal of 300 on catheters for 300 patients, and an investment of $25,000 to support that in URACAP yielded, according to this value analysis, a saving of $348,000. So the cost effectiveness here of thinking about and reducing catheter days, and this is how it's very well documented in the literature that a certain reduction of number of catheter days will decrease the amount of CAUDIs, and CAUDIs ultimately is costing the hospitals a lot of money and the patients a lot of suffering. And the second part is there is a cost to sustainability. You have real estate in the hospitals for pads. And these are major concerns for the society today. There are several concerns, and the transportation, that's another. There are truckloads in a nursing home, truckloads emptying of large packs of adult pads, probably every week or even daily, and you need real estate for that too. The UTI, if we can decrease the UTI. And overconsumption of antibiotics, that would be a major step forward, because that's a sustainability question, according to me, because we need to decrease the amount of antibiotics used, because soon we don't have any antibiotics that are efficient anymore, and multi-resistant antibiotics for gram-negative bacteria is an issue, and other bacteria too. So these are very, very important parts. Then we have the actual waste, the used adult pad. And I will talk about that. You have large landfills in some countries, as mentioned before, 50% of those are incinerated, and we're basically boiling away water. And if for those that are not incinerated and heated up, you might also have a risk of leakage of nitrogen-rich urine into the ground, creating over-fertilization in waterways and so on. And these are actually things that we address with the URACAP female. These are things that can have a huge impact on societal. And as an example, we made a little illustration here in the next slide. We assumed that there would be 137,800 users. I don't know exactly why I came up with that number, but I calculated that those users will decrease the use with 2 adult briefs per day. So they will still maybe use it in the daytime, but for nighttime, they might not need to change it. And the saving is 2 adult briefs. And we calculated the volume, and 1 year use for 137,800 out of what we did calculate over 20 million users that have moderate to severe incontinence. That's a very, very small fraction of that market. We generate like a one-story, one 5-story house with Uricaps, and 38 if you want to have to store the diapers. That's like the volume, I calculated the volume. The next one is more, the last one is a little slide where we divided it by weight, and here we can look at the 90%, basically 90% saving of waste. You create about 1 ton for 100 users. You could create 1 ton of waste, and with the adult brief, it's 51 tons. So savings about 50 tons per 100 users. And if you look at volume, instead of the 5-story houses, which could be a little abstract, we broke it down to a dumpster. Every hospital knows what a dumpster is. So for 100 users per day, that will create waste with, and I included the bag in here and the extension to 1.5 dumpster per year, while it would be 1 dumpster per week or more for taking care of the same amount of diapers. I mean, saving of, and I calculate just saving of 2 diapers per day. So these are pretty very, very telling numbers. So we're talking about a 90% here, and that could have a huge impact on environment. And you also have politically, I mean, we need to put pressure on politicians. Incontinence is, as we saw in the first slide, widespread, and there needs to be resources from the hospitals, from the healthcare, and from the politicians to change the care, to take care of these global problems that ultimately affect the individual on a personal basis. It is important to have a night's sleep. It's important to prevent wounds, to prevent unnecessary UTIs. And there need to be, and I think I'm very happy about WFIPP, who's starting to do a great work, and I hope we can have a great impact on politicians and society to really deal with this problem. And we hope, Christian and the team in Israel and in the US, where we have our team, and hope to make this change that is so needed. And thank you. I think we have time for some questions. And I think that's our last slide, Christy.
It is.
And we really see that this is a new platform. It's an addition. We won't replace all catheters. We won't replace all adult pads, but there needs to be another tool. And we hope to be that agent of change. Thank you very much.
I see that Katharina has a question.
Yeah.
You're still muted.
I'll try to be. So, Katharina from Denmark, I have a question because you have talked a lot about people who are about immobile. And you say that's good for them. What about us who are still walking around and using seven diapers in 24 hours every day? What can we use? Because we are the ones who are putting a lot to the incinerators. So what can you help us with? Because we are moving around, we are not sitting in a wheelchair, but we are very, very incontinent. I'm very excited to hear your answer.
Michael, you've got that one?
I can take that one. This is a new, first of all, this is a new device, and we have to be, and we have our force, we have the anatomy. We know it works if you're immobile or slightly immobile, and you're sitting up. To go out and promise that we will fit mobile, there's a lot of muscles. It's a very complex area. This is a very complex area. We know we have had users, ladies, using it, walking around, not feeling it, but there's something that we haven't tested properly. And to recommend it, it's something that you have to sort of, you try it out. But I would recommend like this. We also said we can't replace all pads and all, but out of the 7, maybe if for the nighttime use, you have to change once or twice, maybe using the UriCap for the night, 7-8 hours when you're partly immobile, when you're laying down in your bed, takes away a few of these diapers, and it also makes your sleep better. Maybe you feel better, so that can be an impact. And then learn about the device. We need to learn. It's a new device on the market. We have to limit our scope. We are not we can't say we're solving everybody's problem immediately, but over time, maybe each patient can evaluate how much they can use it. And as you say, you're pretty agile. You can maybe correct it if you're walking around and you feel like, oh, I need to correct it, and it can maybe be placed in the right place. So I think it's a learning curve for us, for the patient, and I think we have respect for that. So when we do the pitch here, we don't say it is for everybody, but I think it's for everybody sometimes, or for some people all the time. So
Okay.
This is that's my answer.
Just for this case, I'm representing the Danish incontinency organization. I'm in the board. That's why I'm here today. And I'd like to ask you, could you send us some material for our organization so that we could show it to some of our members so we could try it? I would like to be a guinea pig for you and try
Thank
it
you.
walking around, because
Yeah,
we
good.
need experience.
Yep.
And you are very welcome to send it to our organization. And if you have continence.dk, that's our email.
I think I will ask Margot to sort of put together a little list
because
for
we
me.
would like to do something about it, because here in Denmark we haven't heard about it at all.
As an anecdotally, you know, that when you come with a product that is for treating incontinence, and it's not digital health and it is not pharma, the amount of money you get for investors is very limited. This is kind of a taboo area. So
we know.
So we've come a far way during COVID, during financial crisis here. So we have to limit our scope, what we do now and what we do later on. But it's about funding. Basically, the more funding we can have, the more aggressive we can be to do more studies, to do pilots. We need people to support that. So it's partly funding area. So as of now, we've been focusing with Christy on the hospital market in the US and in Israel. And we are also now starting, we have a representative from Bioderm here, which we also signed a distribution contract to service the continuity from when the patient moved from the hospital to the home. And there are people like you also that can call in, the material is enough there, you can put it in yourself, you're ambidextrous, and you can have a good night's sleep. That's an excellent start, I would say. So you do fit, but we have to be sort of setting the expectations in the right place from the beginning.
Okay, thank you.
Thank you. Thank you.
I think I'd like to come in for a moment just to try and collate some of the ideas that are being circulated. I think this idea of in hospitals and the elderly, probably you're looking forward now to other markets, and if you can put together a kind of A4 with some parameters, some ideas of what it costs, when it could be available, and like Katarina says, with the Danish Continence Foundation and other organizations, I'm sure there'll be massive interest. From what you've been saying today, of course, things like UTIs and all the rest of it, the impact is huge. So perhaps it's an idea with the future, but there is a huge future and there's a massive market out there. We need to reduce the waste and we need to make sustainable products. So I think that's very much a take home from what you've both been saying, and the rest is basically up to you. You've got a target audience, you've got a market, you've got all the people like Katarina and so on who probably would want to sort of grab the device right now, so to speak. But yeah, it's obviously that message, I think, is probably where you want to go, and if we can help in any way, then obviously that's the way we move forward. That's the way things get done.
Yeah. No, I appreciate it. I think that it's the lobbying and making the I mean, we have reimbursement in the US, where in each country you need reimbursement also, and it's quite a long process to get reimbursement, and it's individual. In Denmark, Sweden, Holland, you need to have that process. It takes time and it costs money. Basically, I understand what you're saying. That we realize that this sort of the home market, the sort of not the elderly, but that may even mature women that could actually put it in themselves. It's a giant market, and some might even want to be able to can pay for it themselves. We have to go home and look at it, and if you know anybody who likes to invest in this and help us along, that's a big help for us, because every country is going to cost some money up front to take, to put people in place, support everybody, and put support system. We don't want to do it in a sloppy way and then make everybody disappointed. So we maybe are a little focused and take one step at a time. It takes time, unfortunately, and the need is there. I read it very much. I know we get it all the time. Almost every day we get requests now on our webpage.
So I just to wrap up, to say that the presentations, if that's okay with you and you agree, we'll make them available, and we'll make the recording available. And I know that there'll be a lot of people, as I say, not everyone can join in a daytime setting or whatever, but very interesting, and thank you both so much. I'm sure there's going to be a very bright future for you.
Thank you.
Thank you, everybody.
Thank you, Lynn.
We appreciate the
now.
opportunity. And for everyone for attending today, thank you.
Thank you.
Bye-bye.
Yeah, we appreciate being invited. Thank you very much.
Very enjoyable. Thank you.
Thank you.